Hello and welcome to Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. Now, with that being said, in this episode, we discuss focal therapy for the treatment of prostate cancer. Historically, men diagnosed with localized prostate cancer have had to choose between two treatment options: surgery and radiation therapy. Both options involve treating the entire prostate gland, regardless of the size, location, or number of cancerous tumors present. Recently, however, more localized treatment options have become available for prostate cancer that involve focally treating only the tumors rather than the entire prostate gland. So, what are these focal therapies? How do they work? What risks are involved? What advantages do they have over the traditional therapies? And probably most importantly, how successful are they at actually curing prostate cancer? To answer these questions and many more, we turn to a true expert. Dr. Arvin George is an Associate Professor of Urology at the University of Michigan. After obtaining his medical degree from the Royal College of Surgeons in Ireland, he completed his Urology Residency at the Smith Institute for Urology at the Hofstra North Shore, Long Island Jewish School of Medicine. He remained to complete his Endourology Fellowship in New York, gaining additional subspecialty expertise in robotic, laparoscopic, and percutaneous surgery. Subsequently, he completed a Urologic Oncology Fellowship at the National Cancer Institute within the National Institutes of Health. Dr. George's research interests include minimally invasive and image-guided treatments, functional prostate imaging, and focal therapy for prostate cancer. He is an active member of the American Urological Association, the Society of Urologic Oncology, and the Endourological Society, as well as the American College of Surgeons. And now, I bring you our conversation with Dr. Arvin George about focal therapy for prostate cancer. Hello, and welcome to Better Man Clinics. Today, we're going to be talking about focal therapy for prostate cancer. Now, historically, when men have been diagnosed with prostate cancer that needed treatment, they often had to proceed with a treatment, whether it be surgery or radiation therapy, that entailed treating the entire prostate gland rather than the specific cancerous tumor. Recently, however, we hear more and more about focal therapy, new technologies that allow doctors to treat the cancerous tumor or tumors itself rather than having to treat the whole prostate gland. Now, what are these treatments? And what are their advantages to the old tried and true treatments of radiation and surgery? What are the risks of these treatments? Are these treatments mainstream or are they experimental? And most importantly, how well do they actually treat prostate cancer? To answer these questions and many more, we are pleased to be joined by a true expert. Dr. Arvin George is an Associate Professor of Urology at the University of Michigan and an expert on focal therapy for prostate cancer. Dr. George, welcome to the program.
Thank you so much, Dr. Schwartz.
It is a pleasure, and I know I hear this in my practice day in and day out, and we've been bombarded with questions from the guys that follow the podcast online about this. So we're very excited to learn more. Before we dive into prostate cancer or to these treatments, though, I'd love to learn a little bit more about you. The guys love to hear who they're hearing from, and maybe tell us a little bit about your inspiration to go into urology, and specifically in this particular field of treating cancer and these innovative new treatments.
Sure. Well, urology, I was actually trying to avoid urology because it is my father is a urologist as well. And I felt like I wanted to chart my own path and to be able to kind of, make my own mark in the world. But that was my earliest exposure to medicine, was urology. And so I learned to actually really enjoy urology as I started to understand it a little bit more. And then once I ended up pursuing urology, I was really amazed by the innovation in urology. And I think that urology as a specialty tends to lean towards an innovative specialty. So we tend to employ a lot of new technologies like endoscopy, or the use of cameras in diagnosis and treatment, laparoscopy, or minimally invasive keyhole surgery. A lot of it was pioneered in urology. And so there's been a shift towards image-guided treatment, so either using X-rays or CAT scans or ultrasounds or MRIs to help guide treatment. And really, the ability to be able to see and identify the cancer very clearly has allowed us to deliver much more precise treatments. And so it's been a wide open field where we know very little about. And it felt to me like that was an area where I could make a contribution, or at least where I would be able to explore that area with the ability to be able to understand it a little bit better and understand what its role is in patient care and patient treatment. And so I had a number of mentors when I was in residency. And so seeing the work that they had been doing, and seeing how they have really pushed the field forward with innovation and also changed the way we practice medicine, specifically urology, that was really my inspiration to pursuing a career and research, and both a clinical and research career in prostate cancer, and more specifically in focal therapy for prostate cancer.
So such exciting times. I mean, really, times are shifting, treatments are shifting. It's a great time to be in medicine for sure. And you're, for the record, you're the third ureteric bud, as they call the legacy urologist on the program. We had Alexander Kudikoff and Kevin McVeary, both of whose dads practiced urology, and they followed them in their paths. And both kind of mentioned the same thing, right? Their reluctance, wanted to blaze their own trail and couldn't help it. Got sucked into urology. As a urologist, I can understand the attraction. So I understand where he came from for sure. So, I touched upon this, you touched upon this, but for the benefit of the guys, without going into details about specific treatments, define focal therapy for prostate cancer for us.
Yeah. So in a general sense, focal therapy is exactly what it sounds like. It is a treatment for prostate cancer that focuses on an area where the cancer is, focuses on treating that area specifically while leaving normal tissue that's unaffected behind. Now, in kind of more physician circles, we tend to focus on the semantics of it. So if we had to get really, really scientific with our definition, it would be the treatment of a prostate cancer with the application of a margin, which is some normal tissue around the area which is cancerous, to make sure that we got everything, or a safety margin. And then there's other terminology such as partial gland ablation, the gland being the prostate, where it can either be anything that's less than destroying the entire prostate. So it could be 3/4 of the prostate or half of the prostate, which would be considered a hemiablation. But in general, it's treatment of the cancer plus a safety margin of normal tissue around it.
Okay, I'm going to ask you a stupid question now, but because I want to be super clear. How is that different from if somebody comes to you right now and doesn't want focal therapy and gets traditional therapy? What's the difference? What are they getting instead?
Yeah, so traditional treatments for prostate cancer, like a prostatectomy or robotic prostatectomy, which is removal of the entire prostate surgically, or radiation, and there are a number of different radiation treatments, they treat the entire prostate. So if you have a small amount of cancer on the left side of the prostate, the entire left side of the prostate and the right side of the prostate is all going to be treated. And there is a rationale for that. Historically, prostate cancer, as we know it, is multifocal. And what I mean by that is that prostate cancer tends to grow in various different portions of the prostate gland. And so there's only a smaller subset of all prostate cancers where it is really only in one location. And those are the types of patients that we are hoping to identify and offer focal therapy to.
Got it. So before, it was not so much that they couldn't just remove part of the prostate or focus radiation on part of the prostate. They just weren't sure that they were missing other tumors elsewhere.
That is exactly correct. And short of taking out the prostate and looking at every microscopic area of it, it's impossible to tell where all the prostate cancer is. What we're trying to look for are the significant prostate cancers, and those tend to be the ones that look more aggressive underneath the microscope, those that tend to be larger so that we can see them on MRI and biopsy. And any type of parallels in advances in cancer treatment, in my opinion, have really paralleled advances in imaging. So the better that we can see the cancer, the more precise that we can be with treatment. When we look at surgery and radiation, historically, we didn't have the tools in the toolbox to be able to say, hey, this cancer is exactly here. And I'm confident to a reasonable degree that there's not other cancer elsewhere that I need to address. And so for that reason, we typically had to just treat the entire prostate. But over the last 10 years or so, that has changed significantly.
So speaking of that, all right, smart guy. So you can find all these tumors. How do you find them? What are you using to identify that there's more than one or just one? Because, you know, a guy goes to his urologist, generally speaking, most of them this day and age aren't going to get imaging ahead of time. Let's say they'll get a biopsy and they'll say, okay, Mr. Smith, you've got a tumor on the right side of your prostate that we found in 3 specimens. And that's all they tell them. How do you then take it from there to say, okay, there's 1 lesion or 3 lesions or 5 lesions and we can or can't treat them? What allows you to do that you didn't have before?
Yeah, so our gold standard for being able to diagnose prostate cancer is always going to be a biopsy. But really the difference is the type of biopsy that we're doing now compared to what we've been doing previously. What we have historically been doing is largely a blind biopsy. Yes, we use ultrasound, but ultrasound isn't a good tool to differentiate or identify cancers reliably. And so we typically use the ultrasound to ensure that we're spacing out our biopsies throughout the prostate. So most people, most urologists would obtain 6 biopsies from the right side of the prostate and 6 from the left side of the prostate. And we're using the ultrasound to make sure that we're getting into those different regions, or what we call sextants. Now, with the newer imaging technology, and I'm speaking specifically regarding prostate MRI, now that we have prostate MRI, MRI gives us it's like going from a really fuzzy picture to like a super high definition picture. And so we can see some of the nuances of the cancer that we weren't able to identify on ultrasound. And so once we can see it, we can actually put a needle through it and actually sample that area very directly. Now, I don't think we're there yet where we can completely exclude doing any other biopsies. So typically we biopsy that area and we take anywhere from 2 to 6 samples from that suspicious area, and that's largely dependent on your practice and the size of the area that's suspicious on the MRI. And then we also do that standard 12-core biopsy as well, because no test is perfect. And so what we want to, and if we're considering focal therapy, we want to be really confident to the degree that we can that there's nothing else around that we need to be concerned about. So then we get a prostate biopsy report, and that tells us all the locations we took a biopsy, and it tells us which biopsies were positive and which were negative. And with that information, we can understand, okay, this is a map of the prostate. This is what I saw on MRI. The biopsies were positive in this MRI lesion. Everything else was negative, or there was maybe a small amount of MRI invisible cancer on the other side. So that's how we're able to quantify and reliably localize prostate tumors.
So a little bit of a controversial question. As I mentioned, if for nothing else than due to insurance reimbursements and just what's allowed by insurance companies, I would say probably it's a safe bet to say the majority of guys that have an elevated PSA that get a biopsy don't get an MRI first. If somebody gets a biopsy without an MRI, is diagnosed with prostate cancer, and then is interested in focal therapy, I'm assuming they would get an MRI, and the MRI might show 1 or 2 or 3 lesions. Would they have to be re-biopsied through the MRI to confirm that the prostate cancer that was found was indeed in 1 or 2 or 3 of these lesions?
Yes, in my opinion, absolutely. And there's, unless you had what we call a saturation biopsy, which is not typically what is done, but that is an option for men who can't get an MRI for whatever reason. They have metal fragments or something that are there. And that's basically what that is sampling the prostate every 5 millimeters. So you have a true map of the prostate. But absent of that, the reason why you need to do a biopsy based on the MRI information is because you're not exactly sure where the biopsies you took came from. They could have clipped the edge of the suspicious area. They could have missed it completely and actually be a different area than what's identified on the MRI. There's no way for us to know that ahead of time. And so once you have the MRI information, you have to resample the prostate because, one, you may end up finding higher risk prostate cancer. So a more aggressive prostate cancer may be better suited for a more aggressive treatment. And also you may actually determine that this has too many spots in too many different locations. And this is not a person who would be a really good candidate for a focal treatment.
So that actually is a perfect segue. Is focal therapy good for all comers? Or is there a certain subset of patients, of men that have prostate cancer that you would say is the ideal candidate to get focal therapy?
Yeah, this I think is the most important question of all. This is kind of our existential question in this space. And the reason is because can you destroy tissue with ultrasound energy or by freezing it? Certainly, we can do that, right? The question is the outcome going to align with the expectations that both the patient has and what the provider has? And those expectations are generally going to be excellent cancer control and minimal side effects. And so if you don't choose the right patient for that treatment, you're not going to get everything. So you may get low treatments, but you may get low side effects, but you may get poor cancer control. And in that standpoint, you really aren't moving the needle much. So to get back to your question more specifically, what is the perfect candidate? I think that person, it needs to be, in my opinion, if I had to choose a single person candidate, it would be intermediate risk prostate cancer, which is what is called Gleason 7 prostate cancer. We tend to not treat Gleason 6 prostate cancer. And the reason for that is that Gleason 6 is the lowest on the scale. It is not an aggressive prostate cancer at all. And we've followed tens of thousands of men with Gleason 6 prostate cancer, and we know that they do absolutely excellent without treatment as long as it remains only Gleason 6. Higher risk prostate cancers, I think there is a potential role for it, and that's Gleason 8, 9, and 10 with focal therapy, but we just don't know yet. I think that the data that we have is limited. It's out of Europe largely, and we have fewer patients than I think that we can make population-based decisions on, and we don't have the adequate follow-up. And what I mean by that is we don't know what's going to happen 10, 15, 20 years down the line because it's a new treatment. And so with prostate cancer specifically, it's really important to understand that. So again, what is the ideal candidate? It would be somebody who has a prostate cancer that requires some sort of treatment, meaning it has the biologic capacity to go outside of the prostate and cause problems for that person. We want it to be confined to the prostate, so it's not breaking through the capsule of the prostate or anything else that signifies a more aggressive cancer. We do really want there to be some sort of benefit. So if the primary reason is to preserve erectile function, if that person does not have erectile function, then focal therapy may not be the right treatment for them. And then we want it to be isolated from vital structures. So we want it to be away from things that could cause side effects. So the urinary sphincter, which is a muscle which holds the urine in. If it's close to the nerves, which help with erectile function, that would be less than ideal. So there are a number of factors to be able to choose that ideal patient, but choosing that perfect patient, maybe not perfect patient, but choosing the right patient is really important to get the outcome that we're looking for.
Does the size of the tumor matter?
To a certain degree, it does, because the size of the tumor can sometimes inform the stage of the tumor. So if you have a giant tumor that crosses both sides of the prostate, then you're not necessarily really going to end up getting a focal treatment. That preserving a smaller amount of tissue probably is not going to give you any functional benefit in terms of preservation of erections. So in that case, it may be better served with whole gland treatment. There is not an absolute size cutoff, but there are some technologies that shine with larger tumors and some that do perform better with smaller tumors.
And to that same extent, what about prostate size itself? Do men with really large prostates, are they, contraindicated? Does it matter?
Yeah, that's a great question. I think that's a little bit more specific to the technology. And how much you tend to treat. So if you have a giant prostate and you're only going to treat a small amount, the size of the prostate is kind of irrelevant as long as your technology can adequately treat that area. However, if you have a really large prostate and you need to treat a very large amount, you may not have the right treatment to be able to be able to treat, to be able to reach that entire area or treat that entire area. So prostate size is not an absolute reason to not do focal therapy, but it does depend on the tumor location and also the type of technology that you plan on using, and there are many.
Right. And I'm assuming the PSA is not going to matter too much as long as they don't have any evidence of metastatic disease. Is that right? Or does it play a role?
Yeah, it does to a certain degree, because what we do know is that the higher the PSA, or the PSA density, which is essentially your PSA volume divided by a prostate volume, your PSA value divided by a prostate volume, when it's greater than 0.2, that tells us that it's a slightly more aggressive prostate cancer that has a higher risk of failure. And of course, patients who have a PSA greater than 20, they actually move into the high risk category, and so they really wouldn't be appropriate treatment. But within those parameters, PSA is not a reason to not offer treatment.
And patient characteristics, you mentioned obviously if they're not currently having erections, we'll get into that later, but it limits the benefits of it. But are there any patient specific contraindications in terms of other medical conditions or anything else that they should be aware of? Like, let's say they have a pacemaker, they can't get an MRI, anything like that you think about when you say this patient's not a good candidate?
Yeah, we do have some. I do think that there are some general recommendations for a lot of the if I grouped all different technologies together, I think, like I mentioned before, multifocal tumors, meaning in different locations of the prostate, that's not going to be a good person. Somebody who has a fistula, which is a kind of abnormal connection between two spaces, usually between the rectum and the urethra, or the rectum and the prostate, that would be an absolute contraindication. Patients who where that increases their risk. So, for example, if you have Crohn's disease or ulcerative colitis, these are inflammatory conditions of the bowel. Those will increase your risk of developing a fistula. And for those patients, we typically try to avoid an ablation in a lot of cases. Patients who receive multiple rounds of radiation. So there are patients who may have originally had radiation, and then they had a recurrence of their cancer, or the cancer came back, and then they have a repeat treatment with radiation. With that, the areas of the surrounding tissues have received so much radiation, the side effect profile goes up pretty significantly. So those are patients that I would want to avoid it on. And also patients who have advanced disease. So as of right now, it's certainly not an option for men if the prostate cancer has already escaped the prostate and gone to different areas of the body. But even more so, not even more so, but also in patients who have, where it's breaking through the capsule of the prostate, for example, or it's invading areas such as the bladder or the seminal vesicles, which are little organs that are like bunny ears that come off of the prostate. So in those cases, those are signs of a more aggressive prostate cancer that are probably going to be better served with a more aggressive treatment.
Got it. No, that makes a lot of sense. You really want to know kind of who fits in that mold. Now, to that extent, so let's say, you have a patient who was recently diagnosed with prostate cancer, is listening to the podcast, checks off the boxes, say, hey, I'm that guy, and they're coming to see you. What kind of evaluation, even before you decide what type of treatment or whatnot, is there a specific evaluation that they should expect from you prior to being considered for this treatment? Anything specific that needs to be done?
Yeah, so I think that I break those out into two groups: those who have received really prior radiation or prior prostate cancer treatment. And in those men, if they have had radiation and their PSA is starting to rise again, and there's a concern for persistent prostate cancer or recurrent prostate cancer within the prostate, I would want to, of course, have the PSA, have an MRI to be able to clearly, to hope that I'll be able to clearly see it. And then also we have newer prostate imaging tools such as prostate-specific membrane antigen PET scan, and also a flucyclovine PET scan. These are newer imaging studies that really shine in this setting where somebody has had a prior treatment. And the reason for that is because those tests are much more sensitive to identify areas of prostate cancer outside of the prostate, even at a very low PSA value. So what we don't want to do is think that there's nothing else elsewhere, provide a treatment to the prostate, and then a few months later, the PSA rises again, and we ultimately discover that it was due to, spread to a lymph node or spread to the lung or something, or to the bone. And so these tests really help us identify men who truly have localized prostate cancer that hasn't gone outside elsewhere, which means that we have a real opportunity to cure their cancer. So that's in the prior radiation setting. In somebody, the vast majority of patients, they haven't had radiation before. And so it's not terribly different. It's going to be a PSA, a prostate MRI, a fusion biopsy, which is using the MRI information to guide your biopsy, or it can be a mapping or saturation biopsy, like I mentioned. With those key pieces of information, I think that at least from the basic workup, I think that is what we need to be able to understand if that person is a candidate or not.
Got it. No, that helps a lot. Now, let's dive into the therapies themselves. And, I'm sure that you could take 5 podcasts just to go over the different types. But for the guys out there, if you can provide an overview of what are the different options and how do you choose amongst them?
Yeah, so there are a huge amount of options. So ablation just means a way to destroy tissue. And that can be through any different type of energy source. So it can be cryotherapy or freezing the prostate. It can be using laser, which is essentially a light to generate heat. There is HIFU, which is high intensity focused ultrasound, which is using really focused ultrasound beams to be able to generate heat and destroy tissue. There is photodynamic therapy, which uses essentially you get an infusion of a medication, and then when you apply light to the area where it's been infused, it causes blood clots and prevents it from receiving blood flow, and the tissue dies that way. There is irreversible electroporation or application of an electrical current across tissue to destroy cells. There is planar ultrasound or transurethral ultrasound, which is also known as TULSA-PRO. You have microwave ablation, you have water vapor ablation, and there's a number of other technologies that are in development as well. If I focus down on, I would say probably the two most common and most widely available energy sources are going to be cryotherapy to freeze the prostate, or high intensity focused ultrasound or HIFU to focus ultrasound waves to the prostate cancer and destroy the prostate tissue that way. With cryotherapy, essentially you put a needle through the skin below the scrotum, which goes directly into the prostate, and it's all done under ultrasound guidance, similar to how a prostate biopsy is done. And then you freeze the prostate, and at the end of it, you see an ice ball that grows where the prostate is, and you want that ice ball to completely cover the area where the prostate cancer is. And we do that twice. We call that 2 freeze-thaw cycles. We freeze it, and then we let the ice melt. We freeze it again, and we let the ice melt, and then we're done. There isn't a huge amount of preparation for these procedures. They generally men will oftentimes just require an enema, and that's pretty much it. With HIFU, how it works is it uses the ultrasound beams that are focused down into a very, very small point, about the size of a grain of rice. And we apply that grain of rice next to each other across the entire area that we want to treat, and it destroys it with a thermal-based treatment or generates heat to a very high temperature, which destroys the tissue that way.
Okay, so let's as they say, unpack this a little bit. So going back first to cryotherapy, first of all, how are you targeting the lesion? Are you using MRI, or is it like a fusion biopsy where some computer system is showing your ultrasound where the lesion is?
So you can do it in multiple ways. So you can do what we call in-bore cryo, which is using putting the person in the MRI machine and targeting it that way. That's much less common. You can do it fusion guided, which is similar to how you do the biopsy. We have a piece of equipment and some software which will take the MRI that was done beforehand, overlay it or ghost it on top of the ultrasound in real time, so that we can see exactly where it is and we can treat it that way. But there's a lot of people who also do it as a cognitive treatment. So they understand where it is on the MRI, and then they treat it based on where they knew it was within the prostate. And they generally will apply a slightly larger margin to account for any error in trying to localize that area. So you can do it either in the MRI, you can do it as a fusion-guided procedure, or you can do it with ultrasound alone. But you need to do it with some sort of imaging tool.
Got it. And well, let's finish with cryo first. Is that done under general anesthesia or local anesthetic? Is it done in the operating room or in the clinic? How's that performed?
Yeah, I would say that it's most typically done under general anesthetic. However, there are some studies which have been reported in which it can be done under local anesthetic. And even I have done it under local anesthetic in patients who've specifically requested it, maybe a little bit to my reservation, but ended up working out really, really well. It requires a quite motivated patient. But I would say in general, you drift to sleep, you do the treatment, you wake up, and everything is done in about an hour and a half.
Hour and a half. And generally people go home the same day?
Yep. Almost. I don't think there has not been a patient yet that I've had to keep overnight. Every single person will go home. Generally will go home the same day. That's correct. Yeah.
And
it is an outpatient procedure.
Do they require a catheter?
They do require a catheter, and it's usually from about 3 to 5 days. Oftentimes I'll keep the catheter in for about 3 days, unless it's a really large prostate or there's a lot of swelling in the prostate. And that's the main reason why we place a catheter. The reason why we place a catheter is more as a comfort measure. What ends up happening is that when we treat the prostate, the purpose is it generates inflammation. We've treated all that tissue. We've tried to destroy all that tissue. Your immune system gets activated. It's going to cause a lot of blood flow to the area, white blood cells, swelling, and that can make it really difficult and uncomfortable to pee. So we leave that catheter in place for a period of time until some of that swelling goes away. And then you still do have some urinary symptoms for a few days to a few weeks afterwards, like you're peeing more often than usual, feeling like when you've got to go, you got to get to the bathroom immediately, but that settles out relatively quickly. For men who've had prior radiation, I tend to leave the catheter a little bit longer, 5 to 7 days. And the reason is that that tissue has already also received radiation. And what we don't want is really straining to pee at high pressures, which can increase the risk of forming that abnormal collection or a fistula. So with radiation, tend to be a slightly more conservative, leave the catheter a little bit longer. But with most cases, it's about 3 days. And that's compared to, on average, about 7 days for a robotic prostatectomy.
And once that catheter comes out, would you say that patient is recovered, or is there a longer recovery period beyond the catheter?
Yeah, you do have those urinary symptoms, but you don't have those traditional restrictions that you may have with other treatments. I generally say your body will dictate what you can do. You don't really have any specific limitations, but most of the time it's common sense. You're not going to go and try and run a marathon 3 days after treatment. But I would say usually within a week, you're pretty much back to your baseline or very close to it.
And aside from catheter discomfort, how much pain would you say that people experience in the recovery period specifically from cryotherapy?
With cryotherapy specifically, you do have some soreness, and that's just from the needles puncturing the skin, but there's no incisions or cuts that are made. It's kind of like when you get blood drawn, or if you get an IV placed, you puncture the skin, and when you pull it out, it just seals behind itself. Very similar with the cryotherapy needles. You're going to be sore. I generally say, hey, just go and sit in a bag of frozen peas for an hour or so after we're done. That will give you a cooling sensation that will help with the swelling. And then just Tylenol or Motrin for the pain. That's really all that's required. And again, after a day or so, that largely disappears.
It doesn't sound too terrible. Now, when you're counseling patients about risks, specifically, again, we're talking specifically about cryotherapy, what are the big risks that you usually go over with them?
Yeah, so the big ones are going to be the urinary symptoms initially. So the first thing most patients tend to tell me once they come out of the recovery room, out of the operating room, is they say, I need to pee, I need to pee, I need to pee. And that's just the sensation that you need to pee based on the inflammation that we generated in the prostate, and also the discomfort from the catheter that can make the bladder think that it needs to pee. So after the catheter comes out, you do have, typically can notice some blood in the urine, which is very, very common. You can notice over time, you can notice some reduction in the amount of ejaculate or semen that's produced. But in a lot of men, your ejaculatory function is preserved, but to a lesser degree than it would be if you hadn't had any treatment. The small risk of infection, so you can develop a urinary tract infection or inflammation of the testicles. That's relatively common in about 5 to 7% of men. And so I do ask them to take an antibiotic prior to catheter removal to minimize the risk of that. And then probably the most concerning one is the development of a fistula, which is that abnormal connection between the rectum and the urethra. Thankfully, that is exceedingly rare, on the order of less than 1%, probably closer to 0.4%. When that happens, it's typically in men who've had prior radiation. It will oftentimes require a catheter for a long period of time to see if it can heal spontaneously, and that's on the order of weeks to a couple months. Mm-hmm. And if it doesn't heal, it will oftentimes require additional surgery in conjunction with a colorectal surgeon or other people, a multidisciplinary team. Mm-hmm. Thankfully, that is exceedingly rare. But when it does happen, it is something that's very serious that does need to that does take some time to be able to absolutely correct. Then finally, there's the two major things that we just associate with prostate cancer treatments in general. Those two things are going to be, those things are going to be urinary leakage or incontinence. Mm-hmm. So that's the ability to hold your urine at rest. And there's also changes in sexual function or erectile function. Mm-hmm. And I would say all focal therapies are pretty similar from this aspect, because it's not really the technology, it's choosing the right patient. Mm-hmm. From a urinary continence or leakage perspective, less than 2% of men will have any leakage immediately after the catheter is removed. Most all men are completely dry. And we use a very strict definition of leakage. This means like not using any pads and not leaking at all. Whereas sometimes with surgery and radiation, we use a slightly looser definition of social continence, which is using either 0 or up to 1 pad per day. Right. So there's a little bit more variation from that perspective. And from an erectile function perspective, that is going to vary based on a number of factors, based on your age, where the prostate cancer is, what is being treated, what your sexual function is to begin with. If you have perfect sexual function to start with, about 60 to 70% of men will return to their baseline sexual function by about 12 weeks. The rest of men may take a little bit longer. They may need additional support with medications, or their erectile function just will not recover to where it was before. And that should be expected, because as I mentioned earlier, all prostate treatments have some effect on erectile function, but focal treatments in general have the least impact on sexual function of all of them.
If you had to quantify the advantage in terms of sexual function after focal therapy versus radiation or surgery, could you quantify that for the guys out there to know, like, compare apples to apples in terms of the impact on erectile function?
Yeah. So if with surgery, if you start with perfect erectile function, about 30, and you're able to spare both sets of nerves during an operation, about 30 to 40% of men will have erections sufficient for penetration or sufficient for intercourse with or without the use of an erectile aid by 12 months. So that means you'll likely need to have at least an oral medication, sometimes penile injections or the pump, and we'll be able to get you where you need to be, but you're going to need a fair amount of help, and it'll only be in about 30 to 40% of men. I think that the sexual function is the greatest impact is with surgery to remove the prostate. Mm-hmm. With radiation, there's probably about 60% of men will have erection sufficient for penetration by about 12 months. That's with or without the use of an erectile aid. And of course, that's impacted by a number of different factors as well. Radiation is often combined with hormone treatments, and the duration of hormone treatments that decrease your testosterone can impact when you have return of erectile function or sex drive. And as I mentioned before, with focal therapy, about 60 to 70% of patients with perfect erectile function to begin with will be very close to their baseline sexual function, or at least have the ability to have penetrative sexual intercourse by 12 weeks.
Got it. And in the similar vein, you had mentioned that less than 2% of patients undergoing focal therapy have urinary leakage. How does that compare to traditional therapies?
Yeah, so urinary leakage is it's not very common with radiation. So I don't think that there's a huge difference in radiation versus focal therapy, but with radiation, you do have some longer term irritative urinary symptoms. Like I mentioned, the frequency and urgency and the blood in the urine. You can have bowel related symptoms as well, bowel frequency, bowel urgency, that just don't exist with focal therapy or surgery. But with surgery, about 60 to 70% of men by 12 weeks will achieve social continence, or 0 to 1 pad per day. About 70 to 80% of men will reach that benchmark by about 6 months. And the long-term risk of urinary leakage is usually around anywhere from 5 to 10%. So leaking using more than 2 pads per day, more than 12 months after the surgery, is about 5 to 10% of patients. So not particularly common. And urinary leakage is a fixable thing. So there are a number of things that we can do if you have surgery and you have persistent leakage. A lot of men feel that they're resigned to just leaking. That's not the case. We do have treatments if that does occur.
So we spent a good amount of time here talking about, I mean, focal therapy, but specifically cryotherapy. You mentioned, just to go back to HIFU, or the high frequency ultrasound, for a minute. You mentioned with cryotherapy, it involves placing a needle through the skin of the perineum, or that skin underneath the scrotum. How is the HIFU administered? Same way or differently?
It's a little bit different, actually. So if there's an ultrasound probe, or we call it a transducer, and that's placed through the anus into the rectum, similar to how we do an ultrasound for a biopsy. But this is done this time while the patient is completely asleep. With that, it's both able to see the prostate and also treat the prostate with that same probe. And so what that does is that it aims that beam. It's wide initially, and it focuses into a cone down to a specific point and treats the prostate that way. And because there's no incisions or anything like that made, there is virtually no pain at all with this procedure. The pain is largely, or discomfort may be due to the catheter in some cases, but most men have very little urinary symptoms even, or significantly less than cryo. I do think that HIFU probably performs the best with sexual function, but that also depends on where the tumor is located. And most men do very well, have very little pain after HIFU or cryo, but less so, even more so after HIFU.
And do HIFU patients also need a catheter, or they do not?
They do. So all men follow the same criteria in about 3 to 5 days. The side effects are very similar to cryo that I mentioned before in terms of the time ranges and those kind of things. I kind of group those all as the side effects of focal therapy, and the technologies don't differ significantly with regards to the side effects.
Got it. So sounds pretty good. I mean, in terms of being able to tolerate it, it doesn't sound as scary as surgery or even radiation therapy. Now, again, as they say, the proof's in the pudding, right? So the question then is, for even before we get to the pudding, now that you're treating somebody, how do you know they're cured? Because, with surgery, the prostate comes out, their PSA goes to 0, and you're cured, right? And with radiation therapy, there are guidelines for, the PSA goes down to a nadir, a lowest level, and how much it goes afterwards, etc. Are there similar guidelines for focal therapy to understand if somebody's cured? Does imaging involve? How do you follow these patients?
Yeah, so we do have a protocol for follow-up and how we follow these men, but the extent to which we have defined criteria is still a work in progress. So, for example, with PSA, we generally expect about a 50% decline or greater with the PSA, but that can vary because that's going to depend on how much of the actual prostate that you're treating. Are you treating half of the prostate or just a quarter of the prostate? And it also depends on how much PSA is produced by the prostate cancer specifically relative to the rest of the prostate, because normal prostate cells do produce PSA as well. And so there's no way we can know that. And so we generally look at least a 50% decline. Wherever it bottoms out is your new 0 or your new baseline. And then we follow the PSA from there. The other key components of follow-up, especially in the US, are going to be biopsy. So I typically biopsy between 6 and 12 months post-treatment. And that's to verify that there's no cancer that's left behind after treatment. And then, of course, imaging. I think imaging, which is prostate MRI, is going to be the most important part of us determining whether or not there's something there that we need to be concerned about. And again, imaging can also be done anywhere from 6 to 12 months. I do it at 6 months post-treatment.
So using your guidelines for successful treatment, cure, what type of results do you get for your typical index patient, if you will, that guy with the Gleason 7 prostate cancer, intermediate risk, reasonable PSA? What would you quote them in terms of being cancer free? I don't know, 5 years, 10 years out, or is the data mature enough to make those kind of quotes at this point?
Yeah, we do have some data. What I typically tell men is there's about an 80% chance that you're going to be one and done in the first 5 years. Okay, meaning that you don't require a second treatment. But there are approximately 20% or more of patients who are going to require a second treatment, either within the area that was previously treated or a new cancer that becomes apparent later on in the course. And that may be amenable to another ablation or focal treatment, or we may need to transition to definitive treatments such as surgery or radiation or whole gland radical treatments. If we look at the data specifically, we do have the longest series of HIFU, for example, is almost 1,400 patients that they're followed for almost 3 years. And they do have a proportion of those of that group of men who are followed for around 7 years or so. About 1/3 of those men actually did have high-risk prostate cancer. So it's important to understand that this group of men was slightly more aggressive, but the rest of almost 2/3 were Gleason 7 or intermediate risk. Only about 19% of them required a repeat ablation within the follow-up period. And
19%, you said 19. Okay.
19. And only 6.7% required salvage whole gland treatment, meaning did they eventually have to transition to surgery to remove the entire prostate or radiation. And that's over essentially 7 to 8 year follow-up. If we look at cryotherapy, and it also kind of depends on the definitions of what you consider what's a success and what's a failure. If we look at cryotherapy, about 17% of men who have signs of of suspicion like PSA rising or abnormal or normal imaging, and they ultimately undergo a biopsy, about 17% of those will have prostate cancer that requires some sort of retreatment. So my general quote is around 20% within the first 5 years.
Got it. So if you do have to retreat a second time, are the risks that you mentioned higher with the second treatment than with the first?
I do counsel men to say that it is. And the reason is that we tend to be slightly more aggressive on the second treatment because we really want to ensure that we've treated the entirety of the cancer that's left behind. And any secondary treatment, whether that be surgery after radiation or radiation after surgery or radiation after focal therapy, whatever the second treatment is going to have more side effects than if you had that treatment up front as the first treatment. And so I typically counsel men that surgery could be a little bit more challenging. We may not be able to spare the nerves if there's scar tissue on the side that we had done prior treatment. With radiation, typically it doesn't, post-focal treatment, it doesn't make a huge difference. But in general, you are going to have a slightly increased risk of side effects if you're having a secondary treatment rather than a primary treatment.
Got it. So, I mean, something to consider that there is a plan B, but the plan B can have more significant risk. So it's not like, hey, don't worry about it, we can always do this afterwards. You have to keep that in mind, I guess.
Absolutely. And this hasn't been studied extensively or reported on extensively. So this is kind of what we're applying what we think is intuitive here. But we will start to see reports of what that actually looks like, and hopefully it won't be tremendously different.
And when you're comparing the different modalities, whether it be HIFU or cryo or laser, et cetera, have there been any studies to differentiate them in terms of how successful they are in cure or recurrence?
No. I mean, a lot of these studies and technologies and companies will try to claim benefits of their technology over another. But I think it really does boil down to patient selection. So you have to be able to compare apples to apples. We do not have what we call randomized trials in this area where patients are randomized to one treatment or another, which gives us a good idea of whether or not they are one is the same or better than the other. I would say for a large part, it's not the energy modality or the treatment or what you're treating with that makes a difference. It's how you treat the patient, applying the right margin, for example, and also choosing the right patient. If you choose somebody with a really high PSA and lots of cancer and it's more aggressive, it's going to be more likely to recur. So I think it's important to frame it in that way.
Got it. And in general, is focal therapy considered a quote unquote mainstream therapy, or is it still considered experimental? Is it FDA approved, for instance?
So I do not think it is experimental, because we have tens of thousands of cases of men who've had focal ablations, but it is also not the standard of care. And so the standard of care, or the mainstream treatments, are surgery and radiation. And every conversation that I have, I start out with that statement, because it is extremely important for patients to understand that. It's very easy for somebody to be drawn to focal therapy, and oftentimes it takes me just as long to tell them that they're not a candidate. It oftentimes takes me longer to tell them that they're not a candidate than to tell them they are a candidate, because they're already coming with an idea in mind that they want to pursue this. And so it is really, really important to understand that this is not the standard of care. And so there are treatments that are FDA approved for prostate tissue ablation or soft tissue ablation, but they don't necessarily have a specific prostate cancer indication. That's largely based on the regulatory environment. That does not mean that it's not consistent with cancer guidelines. So we do know that doing HIFU, for example, after radiation is included in our guidelines, and it's an absolutely appropriate treatment.
Sure.
Cryotherapy is considered an approved cancer treatment, and that has existed for many years, and cryotherapy has kind of existed since the 1970s. And so cryotherapy is approved for cancer treatment specifically. Now, while HIFU may not have that FDA-specific label of saying treatment for prostate cancer, it does have a code that was assigned by CMS, which is the Center of Medicare Services, which is essentially a government entity which says this is the code for this treatment, and this is specifically for ultrasound destruction of malignant prostate tissue or cancerous prostate tissue. So even though the FDA hasn't provided that indication or statement of label, it is implied based on the codes that are available currently.
And to that extent, I mean, obviously this is going to vary tremendously, but in your experience, do insurance companies generally cover these treatments without like saying, oh, this is just elective or cosmetic or whatever, and we're not going to cover it?
Yep. So the typical reasons why they deny it is because they believe it's experimental. And that is almost never the case for cryoablation. That almost always gets approved. And HIFU, since January 1st of 2021, is almost always approved now, since that code became available. So it is not that common where that treatment would be denied, but it can vary on region. It can vary based on the insurance company that's providing the services. It can even depend on the location of where the treatment is happening, whether it's in an outpatient surgery center or in the hospital, for example. So there are a lot of nuances to it, but for a large part, HIFU and cryo are typically covered by insurance. The other technologies, they have variable coverage that I mentioned, that I had mentioned anecdotally before. And that kind of goes on a little bit more on a case-by-case basis. But I do think over the next few years, there'll be a number of technologies that are going to become widely available for focal prostate treatments.
So to that extent, if somebody has prostate cancer and they're looking for surgery, pretty much, 95% of urologists will be able to do the surgery for them. They can just go to their local urologist, community urologist, and say, hey, let's get this taken care of, or radiation oncologist for radiation. How does one find an expert in focal therapy? I mean, if they're around the University of Michigan, they can look you up, certainly. But if they're around the country, are there resources available for guys to be able to find an expert if they're interested in focal therapy?
Yeah, that's typically lacking, I would say. Now, a lot of times this is guided by the companies that they'll highlight who offers their treatments. And so if you look up a specific treatment, so if you say HIFU, Google HIFU Michigan, or you search it on the internet, you will identify those providers. And then, what I would recommend, and this goes for any procedure, not for HIFU or any focal procedure specifically, but asking that provider with their experience specifically with the procedure that they're talking to you about. That goes for anything, whether that be robotic prostatectomy or ureteroscopy or whatever it is. Patients oftentimes feel bad to ask, and they feel bad to advocate for themselves. But you have one shot at this in terms of finding, in terms of finding the right person for the right treatment. And so none of us take offense. and we're certainly happy to be honest and share our experience.
To that extent, so I mean, that's a great recommendation. What volume or what, I guess, criteria would you use to say this person has enough experience? I know it's going to vary, but if you have to do on a high level, is it like, hey, I do 300 of these a week, or is this like, something more like I do 10 of these a year that's reasonable?
Yeah, so the technical aspects of these procedures are not particularly challenging. This is not a really complicated, technology. There's a lot of technology that's applied, but the actual treatment itself is relatively straightforward. A lot of it goes into the thinking beforehand, again, in terms of choosing the right person. I would say early in my experience, I thought everybody was, I had I would say less conservative rules in terms of who I would treat. And after I treated those men and I started to realize, hey, they have this group of men have an increased side effects with this treatment, or this group of men have an increased risk of cancer recurrence if the PSA is, or PSA density is above 0.2. All of those things come with experience. And so while there isn't an absolute number, I would say, at the very minimum, anywhere from 20 to 50 ablations will put you in a higher volume category compared to a lot of the vast majority of other providers that are around there. And that is, again, because this treatment is very new and very few people do it.
Fantastic. Dr. George, this has been extremely elucidating. I think this has been very helpful for the guys listening in who are curious about focal therapy. Really opened my eyes to a lot of elements of this treatment. And thank you for participating. Before I let you go, I'm going to ask you a question probably unrelated to focal therapy of prostate cancer that we ask all our experts. The name of our podcast is Better Man Clinics, and the whole idea is trying to achieve your best life. You're obviously a very successful person. What is the secret to your success, and how do you achieve your best life?
Oh, that's a great question. I think it is so important to prioritize, I think, a work-life balance. And so it's so easy for us physicians to be so caught up in the work that we do because we're passionate about it and we want to improve patient care and we're dedicated to our patients. But I think that there's been a large focus on physician well-being and making sure that we can not just focus on ourselves, but focus on our families. And I think for me, the key to my success has been my family. Having a very supportive family, my wife, who is also a physician herself, my son. I think they are the cornerstone that keeps me going every day. So I think that the key to my success is undoubtedly my family.
Excellent. Well, that family definitely will keep you going, and it will serve as a rock for it's a great advice for a lot of people, that's for sure. Dr. George, thank you again so much for participating. And to all of you listening and watching out there, thank you for joining us. And remember our mantra at Better Man Clinics: your best life is a journey and not a destination, and use every single day to get just a little bit better. We'll see you all next time.